All right, welcome back for the second keynote lecture of our conference today. We are happy to be joined by Dr. Ramesh Zacharias and Dr. Vikas Parihar for this presentation, which is going to be on the practical applications of therapeutic cannabis. Sort of the other extreme from the talk we just heard from Dr. Prari about a lot of the basic science we have coming out. In way of brief introduction, Dr. Zacharias received his doctorate in medicine and subsequently his fellowship in general surgery from the University of Western Ontario. In 2015, he became the medical director for the Michael G. DeGroote Pain Clinic at McMaster University. He is the principal investigator in a cannabis registry in Ontario. He is also the co-chair of the medical advisory board for the Center for Medicinal Cannabis Research. And he is also the CEO for the Chronic Pain Center of Excellence for Canadian Veterans. Dr. Parihar is a clinical pharmacist at the Michael G. DeGroote Pain Clinic, an adjunct clinical assistant professor in the Department of Anesthesia at McMaster, and he's quite involved in patient education around the use of medical cannabis at the pain clinic. And with that, I will pass it on to the both of you. Thank you.
Terrific. Thank you very much, Jason. I want to thank James McKillop, yourself, as well as Alan Fine for asking Vikas and I to share with you a guide to using cannabis medically. You should be commended for an outstanding conference. I've been able to join on most of the days for part of the sessions and found it extremely informative. And CMCR can play a critical role as a honest broker of the science, the knowledge, to be able to advise clinicians on how to use cannabis medically. Next slide, Vikas. We have no disclosures at this time. These are the objectives for the next 40 to 45 minutes. Over the last 4 days, we could have changed the first objective and basically saying it is complicated. Because if you've listened to all the speakers, you will understand that not only is it complicated in terms of clinical use, but the compound is complicated. It varies in terms of species, strains, and Vikas is going to touch lightly on that. We will then talk about dosing considerations, and then we're going to share with you 3 actual cases from our pain clinic at the Michael G. DeGroote Center. 3 different cases and the role of cannabis. And then Vikas is going to close it out with a research project that is currently being funded by the Center of from the Chronic Pain Center of Excellence. Next slide, please. The reason it's complicated is that there are many routes of administration. There are many products and potencies available. There are multiple active compounds. You heard in the previous speaker, we only have identified 2. There are people who talk about 150, maybe up to 400 different compounds that are active within cannabis, which makes it very complicated. Sadly, there's lack of clinical trials. This is a good example of putting the cart before the horse. When we approved legalization of cannabis without actually doing the trials. But the good news now, and we recently had a meeting with Health Canada where they presented, I believe that the ability to do trials in Canada will be much more prominent over the next few years than it has been in the last 3, and CMCR is involved in some of the trials. And there's also the inconsistency of product labeling. As a good example, I was seeing a patient earlier on today, and he talked about how much benefit he's getting from cannabis, and his bottle ran out. So he ordered a new one from the same company with the same label and says it doesn't work. And that's not a uncommon complaint, because there's complete inconsistency of the product that's available, even though the label seems to be exactly the same as the last bottle. Next slide, please.
And I'll be taking it on from here. and then Dr. Zacharias will come again and talk to us about the cases. So some of the information that I'll go through is already being presented by Dr. LaPerry in far more in better and greater detail. So we'll probably gloss over some of that information. So as Dr. LaPerry said, that the cannabis family is a very, very large family, and you will hear many patients, if you do talk to them, or the lay public, will describe them in three main species: sativa, indica, and ruderalis. And I don't have a picture here, but sativa being a taller plant, indica being a shorter, bushier plant, and ruderalis being almost like a small weed. No pun intended. Essentially, you cannot really describe them as separate species. It's all one plant. There's just a lot of variability. And the reason why this classification system stuck was just an easy way for the initial users or recreational users to organize or classify plants. And people will often assign, well, a sativa is uplifting and an indica makes you feel mellow and chill. But and they'll come to us and say, well, which one would you recommend? And from the science and what Dr. LaPerry said is we really should be looking at the compounds within cannabis as opposed to looking at the plant, how tall it is. And how tall a plant is, or the shape of its leaf or the size of its seeds has no bearing on the actual clinical efficacy. Those genes are not linked. So that's what I really want to emphasize here, is that if you're talking to a patient, is to move away from that language and focus more on what is available within the product and what we know. And Dr. LaPerry said is we've done a lot of research still into THC and CBD, but not so much on the other compounds. So we can only base our decisions now on THC and CBD. And he did mention what he said were cultivars. Now, cultivars are also known as strains. Cultivars mean cultivated varieties. So you will have certain plants that are obviously like a lineage or a family of plants that have been grown in isolation. They'll have different characteristics. And he used the example of a wine. So wines are developed from different grapes, and those grapes grow in one field or another, and they're slightly different from one another. So you have different tastes and complexities with that. So certainly there is merit in saying that certain strains will work, but which strain works, how many of those strains are duplicates or triplicates, we're not sure. So there's no regulation into the naming of any of these strains. So one company A and company B could have the same product and we wouldn't know because they're named differently. So we're going to go over now the broad terms of what Dr. LaPerry was stating was the active compounds that we know of. So THC, I think we've probably discussed that at great length within the conference thus far, so we know of those effects. Same with CBD. But the other ones that he did touch base upon are cannabichromene, cannabinol, cannabidiol, which is CBG. There are many different compounds that are less commonly found in the plant, meaning that there are trace amounts. But they're likely exerting an active clinical effect. It's just that up until now, there hasn't been much funding or research into figuring out if we took these chemicals out, gave it to a patient and observed them clinically, what effect they truly have in isolation. Much of the emphasis has been on THC and CBD. You'll hear a lot of patients and even cannabis companies or growers talk about flavonoids and terpenes. And these were essentially the pigmentation and the compounds that have aroma. Now, these compounds are not found only in cannabis. They're found in many different plants. So you'll have company A say, well, my strain has this amount of flavonoids and it produces this effect. Those have not been validated as of yet. So it's really hard to make any decisions if you're going to guide someone clinically and say, well, you need to have this profile of terpenes and flavonoids. So for now, what we suggest is base your decision-making on THC and CBD. They are the most common. They are also the most potent, or perhaps we could say psychoactive, in the sense that they will have a clinically observable effect. The other compounds are very difficult to base any decision-making on. And this is just a large chart onto the pharmacokinetics of the drugs. So when they are both inhaled, CBD and THC, they will enter the bloodstream relatively quickly. They'll peak within 3 to 10 minutes. So this is why some patients will say, well, I like inhaling because it seems to have a really fast onset. Now, orally taking it does take much longer, and this is common with many oral drugs. So it does take about 3 hours to 3.5 hours for CBD, and a bit quicker for THC, about in 1 to 2 hours for that to happen. Now, the bioavailability too with any type of inhaled form is much more pronounced, so about 30%, which is good bioavailability. And unfortunately, with oral, the gut doesn't metabolize a lot of the compounds, so it does become inactive. So one theoretically has to take a higher dose of an oral product as opposed to inhaling it. Now, you'll know here that CBD and THC will essentially go to many tissues, so many different organs, and primarily the fat storage areas. So it does take a while for it to actually plateau. And I think this is something that I wanted to mention here, and we'll probably see again later, is that you'll have advice from cannabis companies to state that you can change the dose within the 24 hours. So let's say someone's taking 1 milligram. You can double it to 2 milligrams after 6 hours or 10 hours. The issue with that is you're not reaching a steady state with this compound. The half-lives are very long for these compounds. They can last between 2 days to even 7 days for CBD, for the oral component, and for THC could be 1 to 1.5 days. So you need to consistently take the same dose for a given 4 to 7 days to actually see a maximal effect. So when we tell patients to adjust their dose, they should be consistent and take the same dose for 4 to 7 days at a time. Now, these drugs are metabolized by cytochrome enzymes, and we'll talk about this to some degree, but the clinical drug interactions are not very prominent. You'd have to take large amounts. Dr. Davinsky did speak about the CBD trials he conducted. Those patients were taking thousands of milligrams. There you would see some clinically meaningful interactions, and I've actually cited his studies here, but patients are rarely taking that much here. It would be hundreds or even thousands of dollars on medical cannabis to have an equivalent dose. So it's unlikely a patient would get to that level with CBD. Now, this is just an infographic on the just relative comparison of how these compounds go in and out of our system. As mentioned with inhalation, the peak is achieved very quickly, but it's very hard to regulate if a patient's trying to take THC, let's say, for medical use. The threshold in which someone were to get high, let's say, is at 80 micrograms per mil, versus a therapeutic effect is 40. It's very hard, so one can easily overshoot. So this is why personally I don't, and Dr. Zacharias does not recommend inhaling for not only for the respiratory consequences, but also the fact that if someone does not want to be impaired, it's very hard to not be impaired if you take a couple of puffs. And also it's very short acting. So if this is just a single dose of THC, but if one were to need it throughout the day, you'd have to puff and inhale every 2 to 4 hours. And that could be 5, 6, 7 times a day. So you're really having to chase that effect. So it does take time. Whereas the oral equivalent, obviously the peak is lower, it's slower. So, it may not really pain right away or any other ailment the patient is requiring treatment for, but it does last longer. So it acts more like a long-acting medication, far more convenient, and it does allow the individual to titrate up and then potentially not reach the threshold of being high because the peak level is not achieved. So we'll be moving along into obviously different modes of administration. So smoking can take many different forms. So it's not just simply a bong. A joint. Apparatuses such as a bong, there's water pipes, there's hookahs. These are all water-based pipes where the individual is burning cannabis. The smoke is funneled through water, and then what you're inhaling is the smoke that comes out. Essentially, they're have all the same risk, but they all have the same delivery mechanism. So there's generally no differences. There are rolled products, so patients may smoke a joint. Recreational users may use a blunt, which is a mixture of tobacco and cannabis as well. Or actually, that's a spliff. A blunt is a cigar that's filled in with cannabis, cigar leaf. Vaporizing is definitely a more medically appropriate option. Certainly, the risk of vaporizing is likely far less than that of smoking in terms of volatile compounds that are produced. But there are different forms. There are dried cannabis, which you can put into a device that will heat it up and then extract out cannabis oil as you're inhaling it, versus now on the market, or if you see at some Ontario cannabis store, oil-filled cartridge pen, so it's already done for the individual. You should note, though, however, in the US a couple of years ago, there were these illicit forms that were available, and that's what caused popcorn lung, and the likely compound was some type of preservative, not actually something from cannabis. And now topical is present. It's safe. The only issue is that there's limited systemic exposure, which could be beneficial if the treatment is, let's say, a topical skin or muscle type of pain. But if the individual has more of a systemic wide issue, then it certainly wouldn't be the most effective compound, because certainly the delivery mechanism is not ideal. And now, certainly, there's many different oral products available. Certainly, since legalization, there are edibles. Now, at the medical outlets, one cannot buy food or beverages or candy. Those are essentially the Ontario Cannabis Store. And there are some unique dosing recommendations if you were to ever look online. So, for example, there's gummy bears. And if they'll have 5 milligrams of THC, there are some dosing guidelines of eating the leg of one gummy bear and wait an hour or two and see your effects from it. Then bite the lower half of the body of the gummy bear. So it's very unusual, atypical dosing recommendations. Certainly not something that most clinicians are very comfortable with. So certainly, I think if you were to start someone off, you wouldn't want them to try something like that at first. There are capsules. They're made in a very familiar conventional form, and usually they're oil-filled. And they're very convenient, but they're expensive. And then there are concentrated oils. This is what we prefer personally, simply because you can titrate up much finer, and they are less expensive, and they can be used in a variety of different ways, which we'll talk about. And as we move on, this is a busy chart, but it's a good overview of what is available. On the lower end, you'll find that I think it's somewhat mislabeled. This is supposed to be medical outlet, not recreational. I'll have to fix that later. But on the medical spectrum, we'll have very high doses or percentages of CBD, and lower meaning less than 1% THC. And these compounds are relatively safe because the emphasis is on CBD. So even though there's THC, the amount of CBD presence will override the amount of THC there. And this is what a patient can start off with. Typically, though, most medical outlets will have this product, many different products here. And as we move up, you'll see the CBD seems to decrease, whereas the THC will increase. Okay. And up here, you'll find that now recreational growers as well as stores will have very high potency THC products. This is certainly something we do not suggest using for medical cannabis patients, simply because there are certainly much more harms associated with using these products. Now, there are products for medicinal use. We won't really get into too much of these, but nabilone is one that's readily available. It's a derivative of THC. In terms of the pain benefit, there have been some trials conducted, most of which are mixed at best. it's more of a sedative personally. What we've seen it in our patients versus an analgesic. Most patients are not able to tolerate a trial dose and usually discontinue. Sativex is very similar to a medical cannabis product. It is made by GW Pharma, the same individuals that have done the research on CBD in epilepsy. It does work very well for MS patients, but unfortunately it's very expensive and therefore many people cannot afford it. And certainly I've already mentioned the medical products that are available. And usually on the medical sites, dried cannabis oils, capsules, and topical forms are what are available. The edibles and concentrates, which we'll talk about just in a second, are only at the recreational stores. So this is what's most concerning. I think we've had some patients, we'll have a case on this as well, potentially, on certain products that some people are able to make at home, but they can make it from dried cannabis. So even though if you were to prescribe dried cannabis, an individual could make some of these products at home. But essentially, it just depends on the manufacturing method. All of these forms will have 50, 70, sometimes even 80 to 90% THC. And even though the individual is using a smaller amount, the consequences of repeated use certainly would predispose an individual to episodes of cannabis-induced psychosis, cannabis-induced hyperemesis, and even the potential for addiction. Now, we have not evaluated if these are more addictive or would cause cannabis use disorder in certain individuals more so than a regular product, but certainly it is a bit concerning. And therefore, if someone's using this, then I would suggest certainly not to use this if possible. So in terms of dosing, we have to understand that many of the compounds in cannabis are also found in tobacco. So we're not certain, though, if the risk of COPD lung cancer does exist. So if we were to combust it, sometimes there are some volatile compounds that are more common in cannabis than in tobacco. Some are less. A lot of the data is mixed. So a lot of the data that they assessed was looking at tobacco and cannabis users. So therefore, you couldn't really tease out lung cancer, COPD risks. But it'd be important. I'm sure there's some research being undertaken to evaluate independently what smoking cannabis does in the long term. But what we do know is that it can induce chronic cough and bronchitis. And if one is to inhale cannabis, then vaporizing does appear to be safer because a lot of these byproducts are not generated. And the pharmacokinetics are almost identical. So there essentially is no difference, but the difference would be mainly harm, not therapeutic. So if we're looking at risk of THC exposure, one could gather that using a concentrate or inhaling cannabis, you'd be obtaining more THC. Oral would be less THC absorption versus topical would be the safest overall. So if you're wanting to start a compound and you're concerned about the patient's risks or any other factors, then topical would be your safest form. One thing to note, though, if you are going to use an oral product, I'm not sure what the appropriate term is. I know it's a bit controversial, but some individuals can become intoxicated, meaning that if you were to take an oral product, let's say an edible, not know what's in that edible, and consume it, there is a delayed onset. So therefore, theoretically, someone could take a lot of THC and not notice the effects of the THC right away to stop themselves. So what happens is the individual may have cannabis-induced psychosis or even hyperemesis. So it's just, that's one of the risks with oral, which does not happen with topical or even inhaled. Because inhaled, you notice the effects relatively quickly, so the individual knows not to take more. So I think this has probably been discussed in other areas too. So the literature does seem to support against the use of THC in individuals under 25. We do know it's legalized for individuals between 19 to 25, depending on the jurisdiction in Canada. but we do know that the risks of bipolar disorder, primarily triggering the onset and or exacerbating a currently existing bipolar disorder, is an issue, as well as psychotic disorders. We do suggest if patients have tried many different first, second, third line therapies, we can try CBD products in younger individuals on a case-by-case basis. And however, you should note that if you're going to start it, most products in Canada will have THC. There is, even if there's a fraction of an amount, there's still some THC. And in pregnancy, women intending to become pregnant or are pregnant or breastfeeding should avoid cannabis use, as there are safer alternatives that exist. So at McMaster, we do have a high-risk pregnancy patient population, and a fair degree do use cannabis, some for recreational use, some for treating nausea and vomiting during pregnancy. And their assertion is that it's natural, it's safe, but certainly we do know from all of the literature so far discussed in this talk and conference that it's a very complicated plant, and there are many different effects that can occur long term. So therefore, err on the side of caution and don't use it. So what we do suggest is that for patients over the age of 25, we will start off with a CBD-based product. And this is where it really depends on the company the individual chooses. There are many different CBD-based products that change all the time. So what we suggest is something that is 20%, 25% or higher in CBD with low THC. This could be less than 2% or 1%. So we will suggest to patients take it, I say one time of day at first. So I want to know how long it's going to last when they do take it. And I want them to observe the onset, the duration, and also when it wears off. So because it can be challenging with other dosage forms, like a capsule or an edible, I suggest taking it in an oil so we can measure by volume and titrate up slowly and change the dose every 3 to 7 days, because that's how long it takes to reach steady state. So this is a diagram I use all the time that I've created. This is an oral syringe. I tell the individual to, and I don't know, I think all the animation has been removed at the bottom, but every 3 to 7 days, I will tell the individual to slightly increase the volume, and then it'll increase subsequently. And the individual can either put it under their tongue. There is very minimal sublingual absorption, but patients that are able to tolerate it will swallow it, or they can mix it in with something a little bit thicker because it is an oil, and then consume it whole. So what we do expect the individual is after about a few weeks, 5 to let's say 8 weeks or so, they would have titrated beyond 0.5 milliliters to 2 milliliters. And we should see hopefully a response. So there's a bit of math involved with any product that is used, because each product has a different concentration. So as an example, if I have 20 milligrams in a milliliter, the patient's taking 0.5 to 2, then the individual may titrate up between 10 to 40 milligrams, depending upon where they are. And this is typically where a patient will see a response around 10, 15 milligrams of CBD if something happens. If not, we suggest going up to 40. But we do notice that patients will plateau at some point, and that's typically 40, 50, or 60 milligrams. And there certainly is no benefit sometimes going higher. Also, one should note though, even though we're looking at CBD here, there's some THC. And as we're increasing, the THC amount increases, and that's where some side effects may kick in. So just be cautious of that. If a patient has a good response to that once daily dosing, they've gotten a satisfactory response, we then tell the patient to repeat it. So if they're taking it in the morning, they can duplicate the dose at bedtime, or they can do it 3 times over, morning, midday, and then in the evening. Now, this is where it gets a bit complicated. You'll have some patients that will request predominantly THC right off the bat. These are folks that probably have some history with using cannabis, maybe recreationally, and they feel they have a tolerance to cannabis, and perhaps there are some certain benefits they attain psychologically. So perhaps there's a reduction in anxiety and also mood elevating effects. So we still should always emphasize trying CBD products first, and essentially we should be steering away towards using predominantly THC. And if patients find that the CBD product that we initially tried does not work, it's okay to provide them with some THC. But I think this slide's being titled a bit differently. So that's why I think it's not matching what I'm saying. But essentially, if someone's trying a CBD product and it doesn't work, you can actually tell the individual to try a different CBD product, because that one CBD product from company A to company B will have other cannabinoids in different quantities, other terpenes and flavonoids. So you may want to change the product up before changing the amount of CBD. I know this is complicated, I don't have a diagram, but hopefully in the question and answers, maybe someone can ask a question and we can kind of walk through some cases. If you find patients tried CBD products, they haven't worked out, 2 or 3 from different companies, regardless of what other compounds in there, I think you could probably add some THC into the mix and keep the CBD the same. It's interesting, some patients will respond more favorably to THC when it's increased as opposed to CBD. But remember that the psychoactivity or the psychoactive effects are more notable, and you have to be more diligent at monitoring the side effects. So if a patient asks, and this is the titles have been, I think, kind of switched, but if the patient asks for THC only, ask them if they've tried CBD before, and if so, what percentage. So most individuals inform that they have tried a product, but their history is rather unclear. They could have tried something off the street. So you want to reinforce the safety potential and the benefits associated with CBD. And when prescribing, you want to enforce THC limits on medical documents if you feel it's warranted. So if you're concerned about the amount of the individual may end up using, then put some restrictions in place, and most medical providers or companies will abide by it. So this slide is titled correctly. So if a patient requests vaporized or smoked cannabis, I think you want to have a frank discussion and just say, have you tried oral? If they haven't, you want to possibly suggest to them that there are certain disadvantages with inhaling. There's a very quick onset, and the fine titration is not really possible. So taking 1 to 2 puffs for relief, one can easily take 2 to 3 puffs and get high. It also wears off quickly. And like I said, there's multiple doses that are required. And there are certain situations, though, in which some patients unfortunately may have to utilize a different delivery mechanism, such as inhaling. Some patients have Crohn's disease, IBS, gastroparesis from other conditions. So therefore, vaping and smoking would be probably more efficacious because the oral absorption is reduced in those patients. So I think for time we're doing quite well. We're going to go to the case studies. Dr. Zacharias will go over these.
Okay, thanks, Vikas. Before I talk about the cases, I first started to prescribe synthetic cannabis in 2008. So we're coming now onto almost 13 years of working with this particular product. And Vikas has highlighted one of the complications is the routes of administration. I actually saw 4 patients today, all of whom are on cannabis, and every one of them is using all 4 routes. Some of them are smoking, some of them are vaping, some are using topical, and some are using oral. So understanding the pharmacokinetics as to the route of administration is extremely important for anybody who's going to manage a patient on cannabis. And over the years, I've seen significant benefit for people using cannabis, but also I have seen absolute disasters where extremely high THC in patients who are bipolar and previous substance use disorders completely decompensated. So I'm one who says this is a good product, but like anything else, screening the patients early, coming up with the right diagnosis, determining what product, what route of administration, and the constantly used start low and go slow is the way to prescribe it. I had a patient who was an elderly patient who was started on cannabis and was advised to start at 0.1 and every day increase by 0.1 of the oil. And by the end of the first week, she was staggering. If you notice what Vikas said, you start low, even if it's 0.1, and then go up anywhere from 3 to 7 days. So that particular patient would have been similar to this case one of an 82-year-old married with several children, grandchildren, non-smoker, leads an active life, history of back pain, hypertension, lipidemia. These are all patients, actual patients we've had in the clinic, osteoporosis and asthma. You can go to the next slide, Vikas. So for 17 years, I was a medical director in nursing homes. So when you look at this particular patient's current medication, they're on 23. At times, I would have people come into the nursing home with 30 different medications. So goal number one was to get rid of some of these medications. But what's interesting about this particular patient is that when you look at the medications that they're on, there are a couple of ones that you need to be aware of, especially if they're going to use cannabis, that the compounding effect of their hydromorphone and their pregabalin will be very sedating for them. There's no reason why this patient couldn't get cannabis. It's just understanding the route of administration, what are you looking for in a product, and how you would advise them taking it. You can go to the next slide, Vikas. So you'll notice on the primary complaint, persistent pain can be managed by medications. If they are candidates for epidural steroid injections, you could do that. I would say in the last 3 years of my pain practice, I've almost had nobody come to the clinic looking for opioids. And I would say the majority of them are looking for cannabis. So one potential on this particular patient that was tried was, can we add cannabis and see is there a possibility of reducing the opioid medications, understanding the relationship. The youngest patient that I have prescribed cannabis to has been around 25 or 26, and the oldest has been 96. And even in the 96-year-old, we were able to introduce it without any complications. She had hypertension and diabetes, and we did a trial. Vikas and I have been involved in the data registry, and you need to do an appropriate trial of cannabis, which in the majority of cases is at least 4 to 8 weeks before you stop giving it. In her particular case, at 8 weeks, it wasn't helping her, so we discontinued it. Next slide, please, Vikas. So when you're going to give it, one of the concerns with them, if they're going to try to inhale it, if they have asthma, they're going to have a major problem. But in this particular case, we didn't even consider that. So understanding the pharmacokinetics of the product, the pharmacodynamics, how it interrelates, and in this particular patient, they were started at a very low dose and increased. Most of the time, I start my patients at nighttime. Not that it couldn't be started in the day, but it gives an idea if they are going to be much more drowsy, I'd rather start them at night. And then once you get them to a stable dose at night, you can introduce a second dose in the morning. And those two doses initially are always CBD. And ultimately, if you're going to have a third dose, you can then have a blended THC CBD at bedtime. You can go to the next slide, Vikas.
So
this is your patient, so go ahead.
So this is another case, and I'm probably going to talk about patients who've tried medication and it doesn't seem to work. So this is another case of a retired nurse, non-drinker, no tobacco use. And her main pain problem is rheumatoid arthritis as well as post-herpetic neuralgia. So you have inflammatory pain condition and also neuropathic pain condition. She also has glaucoma as well. So she's on some meds for rheumatoid arthritis, some blood pressure medications, several different eye drops for glaucoma, and then she's also taking something for her nerve pain as well. And she's on a bit of an opioid, a very low dose. So we started this patient. She's been on medical cannabis now for several months and found that she was able to tolerate the CBD oil. So she was taking about 20 milligrams or 1.2 milliliters. So she's on about, I think like 24 milligrams twice a day. She did note some small reduction in joint pain, but there really wasn't much effect from her area with post-herpetic neuralgia. So it's not uncommon for a patient to have multiple pain complaints. We'll have one area of pain that is treated by a medical cannabis trial versus another has no effect. And from our experience, we know that medical cannabis can work for an inflammatory type pain and neuropathic, but teasing out which patient's a candidate, which patient will respond is really difficult. And it's simply having the patient just trial that medication. And I think that goes with any pain medication. Most will only have a number needed to treat of 5 or 6 to see a benefit. Most patients who come to at least the clinic that we run, that I'm in personally, they do have concerns about THC use, so they simply they don't want to try it out. But sometimes you have the patient's family members who've tried THC and will end up suggesting to their parents, well, to smoke it rather than using an oil because it's more effective. So in regards to this patient's response to cannabis or CBD, she hasn't had any bothersome or clinically significant effects that are of concern, but she's shown very little efficacy. So in this scenario, I wouldn't really give up on a CBD oil at this time point. I would suggest the individual try another 20 milligram per mil product, possibly from a different company, because of the other active compounds that may be in a different abundance. So it's coming back to this entourage effect. The whole group effect of the chemicals with the CBD and THC may be helpful. Now, if after trying 1 or 2 different CBD products, there's still no effect, we could try a bit of THC, increase that a little bit, and just monitor for side effects. But I wouldn't necessarily go to inhaling. It seems to cause more issues than help, especially in an older population. So the third case.
Yeah. So this is a patient of mine that was just in our interdisciplinary pain program and discharged about 8 weeks ago. He's a 29-year-old veteran who'd been in the Canadian Armed Forces since the age of 18, suffered repetitive strain injury, and in the military you get medically released, which means you can't do the work that you were brought in to do. It creates a lot of challenges for a 29-year-old who his whole dream was to serve and now is being told couldn't serve. So what happens when they leave the military with chronic pain, unfortunately, they're at risk for alcohol dependence. So one of the things that happened with him was he started to consume a lot of alcohol. He had anxiety prior to all of this, and he had quite severe MSK pain in his ankles as well as his knees and shoulders. You can go to the next slide. So when we saw him, and he was admitted in early February, he had indicated that previously he had tried NSAIDs, 3 different kinds, 3 different opioids, had been on 2 antidepressants, and was not doing very well. When we saw him, he was on tramadol as well as pantoprazole, over-the-counter supplements, and he was consuming 7 grams of cannabis. You can go to the next slide, Vikas. Of which 5 of them had 5 grams had been authorized, and then he was buying another 2 grams. And what was interesting, he was using a whole variety of methods to consume it. He had some oils. He had CBD oils, THC oils. He was smoking with a bong. He had dry products, and he had edibles. So when you listen to him about what he was consuming all day, most of his day was spent in trying to figure out how much cannabis to take and what route to take. And so we're very fortunate at the DeGroote Pain Clinic. We have 2 outstanding pharmacists who are extremely knowledgeable in the area of cannabis and have created the education program for our patients. One you have met today, Vikas Parihar. The other one is Anna Rogers, who works in the interdisciplinary team. So when we assessed him, he was extremely anxious. He couldn't remember what he was taking, when he was taking, and not only that, he felt his pain was not well controlled. Go ahead to the next slide, Vikas. So in week 1, we started to look at reducing the amount of his THC oil that he was taking. And we actually cut it in half. And we cut it in half over 1 day. Understandably, he did not have 2 very good days subsequently, but eventually it was out of his system and he was doing fine. We then adjusted his dose to primarily be CBD, where he would take morning lunch and he would just take the oils, get away from smoking, get away from the edibles, so that we can have a honest discussion of how much he was taking. So week 2 and 3, he started to discontinue his edibles and reduced his THC. And his comment after week 4 was his girlfriend who lived with him was saying, "You've been stoned for the last 5 years on the cannabis you were consuming." She said, "You're like a completely different guy." He was less suicidal. His pain was better. He went down from a 6 to 7 down to a 3 to 4. And for the first time in years, he was sleeping 7 to 8 hours consistently. You can go to the next slide, Vikas. Go ahead, Vikas. Take a few minutes to talk about the research initiative that you're leading now. You're muted.
Sorry. So we're going to be talking about another registry. So the previous registry that Dr. Zacharias was referring to was one we conducted at the Michael DeGroote Clinic from 2016 till 2019 on the general population, where we were attempting to monitor patients every 6 months and have them complete a battery of validated tools and surveys, and to see what trends we could see from cannabis use. So let's say, would using THC cause a certain effect, or would CBD cause another effect? Simply because, as we've already mentioned several times before throughout our series of talks, research on cannabis is somewhat restrictive, and conducting RCTs is not possible, so we can only do it on an observational basis. So this study is designed at looking at veterans, and it'll be looking at individuals with a valid medical document. Our main outcomes or areas will be assessing our pain, sleep, and anxiety. And actually, this is labeled incorrectly again. I'm sorry. This is actually for the Shoppers Drug Mart study. Sorry, we had someone compile the slides. I'm going to skip this. Let me go to this is, I think they've been amalgamated for some reason, but essentially our study is not going to be registered with Shoppers Drug Mart. We're just going to be measuring these individuals at baseline, week 6, week 12, and week 24, and we're going to be administering these surveys. And essentially what we want to do is track to see certain patient outcomes, so whether pain changes with their regimen, sleep and whatnot. But the amount of surveys that we're going to administer are quite a bit different. They're not as extensive as previously done before because recruitment was low initially. Okay. So in terms of the takeaways, when considering cannabis, what we've emphasized here is you really need to have a good patient history, do a thorough assessment of pain and sleep and mood and other factors that are associated with pain, and consider what risk factors are associated before starting cannabis. And the individual. Screen for any type of substance use disorder. This could be alcohol use disorder or another drug use disorder and cannabis use disorder before authorizing cannabis. And we do emphasize using oils simply because it's far easier to titrate and for you to monitor if you're a clinician, and increase slowly and monitor effects and tell the patient, unfortunately, to not expect a benefit right away. It'll take time. And eventually, if you feel comfortable, the patient feels comfortable with CBD once or twice a day, then you can consider adding THC or perhaps reaching a level where you have an even amount of both. And I think we're done. We've just gone over the references and any questions.
Thank you very much. I think as we've heard, the idea that it's a wild west out there is a strong perception. But I think when you bring personal experience with so many years of authorizing use and practical use of cannabis for medicine, I think hopefully the people listening have found that useful. I know I have. So we have some questions. First from Carol. When prescribing, many companies request uncapped THC, which makes me uncomfortable. I would prefer a 30% cap. How do you suggest I prescribe?
From my perspective, I just tell the patient, because I write all the documents for the doctors, I just tell the patient I'm not sending it to that medical provider or that company. There are several large, I'm not endorsing any particular company, but we do go through Shoppers Drug Mart. They're very good at enforcing. I know it's optional. Health Canada has made it optional for it to be enforced, but Shoppers Drug Mart will enforce it. Spectrum, Tilray, many of the major companies. So I think you would be able to do that.
Next question. Thanks for the presentation. Please, can you speak to the efficacy of topicals as it pertains to pain management?
Do you want me to do that, Vikas?
Sure.
So topicals as it relates to cannabis and topicals as it relates to other products. So I use topicals quite a bit and have been for many years, and have used a combination of 4 different compounds, but there are 17 that you can use. So I use things like lidocaine, amitriptyline, ketoprofen, and ketamine. That's usually my go-to, but you can use 2 or 3 or even more. And there are some that add in the pregabalins as well into it. Then if you want to talk about the topicals in terms of cannabis, I have one right now and I just saw him today at 1 o'clock, and he's been using it. He finds it very helpful. And similar to the other topicals, it's great, but it's very short acting. It'll kick in about 30 minutes, and it's usually gone in about an hour. And that's one of the challenges. But the advantage is you can carry it with you if you're going out, if you are now allowed to go out with COVID-19. So you can take it with you. The challenge is it just doesn't last that, but it's a safe route to administer, and either the cannabis or the other products, a good way of giving it with reduced systemic symptoms.
Great. Another question from Dr. Suraj Tandon. What are your thoughts and recommendations to patients pertaining to immunotherapy agents such as nivolumab and the like? Similarly to antiplatelet agents with concomitant cannabis use, given that there is established evidence of reduced efficacy of these drugs?
I think I'll take this one.
Sure.
So when we have a patient on any type of biological, or perhaps they have a very severe comorbidity. So we've had individuals with renal transplants and they're on a whole host of drugs. I usually get referred and I'll end up looking up the potential for drug interactions. So for individuals such as that, it's kind of a contraindication or relative contraindication, because you have to balance whether or not treating the pain with cannabis versus something like an immunotherapy. What are the patient goals? And I think if you're using an immunotherapy such as that, that's more important, and that would trump using cannabis in that individual. And in terms of the antiplatelets, I haven't really reviewed the literature on, I think you're referring to the NOACs, the novel oral anticoagulants. I think, it really depends on the type of product that's being used. So if it's a topical, then certainly the individual can use it because the systemic exposure is less, possibly even a lower dose of an oral. But I think when you're getting into inhaled forms, there's likely going to be the interactions you're speaking of. So I think it's just grading that risk and monitoring for that. So I don't know if it's an absolute contraindication there. And okay. I could probably speak about the second question. It's a bit longer. So why would the dose of a 67-year-old, if she's taking, not be titrated up to 40 milligrams per dose if it may be effective? A therapeutic dose may not be observed yet. Given the effects, why would this not be considered as a next step before switching to another product entirely? That's equally possible. I think it's possible for the individual to go up to 2 milliliters twice a day, but what comes into play, unfortunately, and I think you're correct, is cost. So most patients can't afford to take 4 milliliters per day, or even 6, 7, 8. So I think that's why in this situation, but yes, you're right. I think if possible, we would go to 2 milliliters per dose twice a day before switching.
So similarly, from Roman, what is your watchful dose of THC in your cannabis trials, and what is your usual maximum of CBD that you may titrate to?
I think with THC, for the most part, we try to cap it off at about 20 to 40 milligrams per day. I think for most patients, especially if they're naive, I think, because they're not used to this product at first. You will have individuals who've taken THC for many years who that use more. So I think for that individual, you may have 100 or even 150 milligrams. But certainly from the patients that I see, which are naive, then I just cap it up at 20 to 40 milligrams. And in terms of CBD, there really is no watchful dose. Actually, Dr. McKillop and I and Dr. Busse ended up doing a CBD review. A lot of the data was from Dr. Davinsky's research, and they were able to provide patients with 6,000 milligrams of CBD. And although there were some side effects, it was relatively mild considering that such a large window of drug was given. So there really isn't a watchful dose of a CBD.
Also from Roman, can you talk to how expensive it can be to provide a full dose of a CBD product, and how many of these may be covered by third parties?
So for example, if on some of the websites, a bottle of 20 to 30 milliliters is as low as now $20, which is low nowadays, but it could range all the way up to $150. I'm not sure why there's such a variance in terms of the cost. I'm sure it has to do with the manufacturing and perhaps consistency, but I haven't been able to validate as to why there's such a difference. So, and in terms of third party, Veterans Affairs will pay for it, hence why we're doing the research in veterans. And some third-party insurers, Sun Life, Manulife, and Great West Life will cover only for multiple sclerosis and cancer. Because that's where a lot of the RCTs were conducted in. And unfortunately, without further research, which is what we're advocating for, many other conditions can't be covered at this point because insurance companies will look at the evidence, which they're which there's insufficient forms.
All right. From Elizabeth, in your slides, it was recommended against using cannabis for under 25 years old. Does this include CBD or only THC products? For example, would CBD or CBG oil be appropriate for pediatric IBS?
In terms of we have given CBD to younger patients. I don't think that would be a contraindication. I think you just have to be aware that there's still a little bit there. So there might be 1% or less of THC. It's likely not clinically significant, but if you're titrating upwards, if you're giving 2, 4, 5, 6, 7, 8 mils, the amount of THC will be increasing, and therefore you may get some side effects. So I think it would just be safe to use a CBD product, but if you're using a strict THC product, we simply don't suggest it, or something with an even amount of both.
I think one of the speakers earlier this week presented some papers around the developing brain and the risk with the developing brain, and that even into their 20s, there's still development occurring. So it, as I said, it's complicated because you have for seizure disorders, for some of the Dravet syndromes, that CBD has been approved. So you have to weigh the risk and the benefit. But certainly THC, and I'll make one comment about people who are bipolar. Be extremely careful about giving them any THC. It will tip them. CBD does not seem to have the same effect on them, but with bipolar patients, high dose THC has a potential problem for them.
I see 4 more questions, so we'll try and go through them. From Linda, we have noticed with patients from our clinic that the use of oil is being replaced with capsules. Our older patients often suffer from issues of eyesight and/or tremors. I believe the metered dose sprays may be better, but people are telling us they do not like these. What is the downside of capsules? You seem to prefer oil.
I think capsules are good. They're very convenient. They're tasteless. The issue is when you're first titrating. So when you're titrating, maybe each capsule has 0.4 milliliters in it. And it's interesting, some patients can't tolerate those increments. So you go from 0 to 0.4 to 0.8 to 1.2. You may find that the dose that they tolerate is somewhere in between. So it might be 0.6. So it's hard to achieve with a capsule. So I think if the individual starts off with an oil and they can kind of round up to whatever they can estimate in a capsule, I think that would be suitable. But bear in mind, capsules, there's more processing. They're usually twice the cost. So I think that's why I steer away from them. Many of my patients are on government assistance, so they can't afford that.
One comment I will make is the 96-year-old, I started her on oils. And so her daughter would come once a week and draw it up for her mom. She was just taking it at a bedtime. So we ended up using her family to be able to draw it rather than give her capsules. And we had a good run with it for about 8 weeks, and she had no complications, but she really didn't find she got benefits. So we then tapered her down as we got rid of it.
From Colleen, it looks like just a clarification for the vector study. Are these veterans using medical cannabis, but not necessarily registered through shoppers? Is that correct?
Yeah, so sorry, there's 2 separate studies. There's one separate for shoppers, which I won't talk about. The vector study would be anyone who's using cannabis. They could be with any provider. And it doesn't have to be necessarily from a medical producer. They have to be using it for therapeutic purposes. So they could be even growing it themselves. We simply want to measure what they're using, how much they're using, and how they're using it. So, and we're also going to be assessing veterans not using cannabis. So it's open essentially to all veterans, depending upon which stage we're at in the study.
So the last 2 questions, one from Margot, one from Terry, both have to do with interactions. Margot asks, can you talk about particular high-risk meds for pharmacokinetic interactions with CBD? Is there a daily dose above which there is heightened concern? And Terry asks, Vikas, have you seen any clinically significant interactions between cannabis and warfarin? I know there have been case reports, and the CYP450 effects certainly support the possibility.
Yeah. So for the first one, I had a case study that I published in the clinic, and we had a patient on tamoxifen, and tamoxifen is used, for those who don't know, to prevent the recurrence of breast cancer. So when my colleague and I, our pharmacist, we noticed this patient was on it, we decided to measure. We're able to get Dr. Zacharias and some funding to draw some blood levels. We asked the patient to come off of her tamoxifen. We did notice that the conversion of tamoxifen to its active form was inhibited by CBD, even at a low dose. So I think it's important for individuals to be on certain CYP, I think 2C19 and CYP3A4 drugs, especially the ones that require conversion to an active form, or potentially that would accumulate causing effects. So certainly with warfarin interacts with many drugs. So I would be hesitant with anyone on warfarin to take CBD. And if they are, then they should go for more blood work until things stabilize. So I don't think it's an absolute contraindication. But certainly tamoxifen comes to mind. There are some anti-epileptics. If you look at some of the studies from Dr. Davinsky's group, they did detail some very significant interactions with phenytoin, I think. And I think one of the other drugs they're assessing at the same time. So those come to mind as prominent interactions.
All right, I think we'll stop there looking at the time. There is one more question, Vikas, maybe, or
Sure.
Ramesh,
I don't have any knowledge of the transdermal patches coming. I'll be honest with you, there's very scant evidence on topical drug delivery of cannabis compounds. So a lot of the stuff that I comment on is based on what's in the research. It'd be interesting to see if someone can provide us more insight into that.
All right, I'll turn it back over to James and Jason for final thoughts and closing out the conference.
Thank you, Alan. And thank you so much, Dr. Zacharias and Parihar. That was a great, great talk. I think it really highlighted the kind of caution and critical thinking and the art that comes into the medicine of authorizing and managing medical cannabis treatment.